As Dr. Smith mentioned, I'm the founder and director of the Camden Center, which is a PHP and IOP program that has associated gender-specific transitional livings. We have a location in Los Angeles and in Menlo Park. I'm also the founder and director of the UCLA Dual Diagnosis Program, but UCLA doesn't need me to help them promote them, so we can just talk about the Camden Center. Couple things. So one is, I noticed when I got the brochure or the email blast for this talk, that there was an error that had been made in the title, and I was like, oh man, I can't believe the people who are putting on the symposium screwed that up. And then it turns out I actually screwed it up. So the title actually is Biogenic Monoamines and not Psychogenic Monoamines, as it says in your brochure. So I'm not sure how relevant that is, but just in case you were wondering about the discrepancy. So I have one of these anecdotes that I was going to start off with that part of my brain is saying, you know, you probably shouldn't start with that. And then the other part of my brain is, which is usually the one that wins out, is saying, just fuck it, go ahead and say it. So, this topic of that I'm going to be discussing today brings me a little full circle. So I grew up in the Bay Area, and when I was 17, I started experimenting with psychedelics, and had a few positive trips on psilocybin mushrooms at the beach with my friend Tracy Sires, in case you know her, and those does somebody actually know Tracy Sires? She's a dentist now, apparently. So I probably should not. This is a good example of what's likely to happen for the rest of this talk, actually, what just happened right there. So, so if any of you get your dental work done by Tracy Sires, I'm sure she's probably not taking mushrooms anymore. We were 17, and she was a very otherwise responsible young woman. So in any case, I'd had some good experiences on mushrooms, and so I decided to take them another time, except this time I was like, well, I don't really want to go to the fucking beach. I was at home with my girlfriend, and I said, I'll do them here. And so I took them at home, and of course, like most of your who have done mushrooms probably have experienced, you know, I ate some, and then I'm like, well, that didn't work, and so I ate the rest of the bag. And then I remember I walked into the kitchen, and my mom, who was home at the time, started yelling at me about one of the 7,000 things that she spent my childhood yelling at me about. So right when the mushrooms kicked in, and I didn't know what was happening, but something very, very, very terrible started happening in my body at that moment. And I freaked out, and I ran back to my room, and I grabbed my girlfriend, and I said, we got to get the fuck out of here. And she's like, what's going on? I'm like, I don't know, but we got to get out of here right now. So we got in the car. I was driving, of course. Making really good additional good decisions as a 17-year-old, and I got on 280 and I'm driving and I'm like freezing and like putting on the heat and then rolling down the windows and then I'm like shivering anyway. And so when she's like, where are we going? I'm like, we got to get to Stanford Hospital. So on my way to Stanford Hospital, I don't know what happened, but I ended up in the parking lot of my orthodontist office. Spent probably the next, I don't know how long, it seemed like maybe 4 or 5 decades, but was probably only about 3 hours, in probably the most acute anxiety that you could possibly imagine a human being could experience. And then eventually, you know, and in my little the Honda Accord, like just curled up in the fetal position, and then, you know, fortunately was okay thereafter. So, you know, that experience, which, and that story in multiple regards, I think can give some clue as to why I ended up in mental health care. But, you know, I think what's really important, I think, when we're talking about the types of agents that we're talking about at this conference, So phenethylamines like MDMA and tryptamines, so psychedelics like LSD, psilocybin, psilocin, et cetera. You know, I think what is important as, or what I think is important as a physician, is that we really understand to the best of our abilities, you know, what are the real risks and what are the real benefits that we can offer any particular patient that we're working with. And unfortunately, I don't think that the way that these agents are being talked about, and this is what the talk's going to be about, I don't think that the way that they're being talked about a lot of times enables, in a pragmatic way, a specific clinician to be able to really think about, for this particular patient that's sitting in front of me, is this something that's likely to help them? If it is likely to help them, is it something that's also going to be associated with some risks, right? So like, why was it that when I was at the beach and taking shrooms with my friend, everything was fine, but then when I was at home and my mom started yelling at me when I was 17, that I ended up, okay, that's an obvious answer, it's kind of rhetorical, but I think it's an important question for us to be thinking about, right? Especially at the dawn of what I view to be kind of a new era here, which is, you know, unfortunately for stupid political and sociological reasons, these agents have been essentially shielded from legitimate research because they've been Schedule I agents, which basically means that, you know, it takes a lot, you gotta move mountains in order to do research on them. Fortunately, that's changing. But I think as we're moving to an era where these agents are going to be likely accessible, I think it's important for us to start thinking in pragmatic ways about how we can do accurate risk-benefit assessments for particular patients. So that's basically what that fancy title that I came up with means. By the way, that title's kind of funny. So I was in a car accident in December, and it was bad. I broke both my ankles and was awful. I got put on a lot of gabapentin. I'm a recovering opioid addict, so opioids were kind of off the table for me. So when I remember I woke up one morning after a particularly bad night of sleep in a gabapentin haze, and that title came to me. So anyway, I'm like, that's what I'm going to talk about at the David Smith Symposium. And I'm like, now people ask, like, oh, what you're talking to me about? I'm like, oh, I don't even know if I can remember it. Like, I can say it. It's hard. Anyway, okay. So hopefully the talk itself will be a little more cogent than the title. Okay. Oh, is this a pointer too? Wait, hold on. Oh, awesome. Okay, that's gonna make things go well. And then, there we go. Okay, disclosures. I don't have any conflicts of interest. Learning objectives. List which neurotransmitters belong to the class of biogenic monoamines. Oh, one other thing. So I was really overambitious with this talk, and there's like no way I'm going to really be able to do justice to the stuff that I wanted to talk about in the short period of time, especially that I just wasted 10 minutes talking about that bad mushroom trip. So this is by necessity going to be a little bit superficial, and I'm probably going to have to like blow through some things pretty quickly. Hopefully there'll be some time for questions at the end if anything's unclear. Okay, so list which neurotransmitters belong to the class of biogenic monoamines, describe the emotions and behaviors in humans mediated by the biogenic monoamine neurotransmitters, and explain the differential role of Oops, there's a little bit of a lag. Let's see if we can go back. There we go. Explain the differential roles of dopaminergic versus serotonergic agents in effective pharmacotherapy for trauma-associated psychiatric conditions. So that's what the learning objectives are. AV guy, which way should I point the thing towards you? Okay. Good. Okay, so what are the biogenic monoamine neurotransmitters? So they are the imidazolamines, even though there's really only one, which I'll talk about in a minute, the indolamines and the catecholamines, which are coming. Uh-oh. At the screen? Oh, there we go. Okay. Now you can see my legs. Okay. All right. You guys are a tough crowd. There's going to be some processing I have to do after this talk. All right. So, okay, so histamine, we're not really going to worry about histamine. So I can tell you a little bit about it. So derived from histidine, all of these are derived from amino acids. So it's derived from histidine, which is an amino acid. It mediates wakefulness, and it acts as a neurotransmitter in the central nervous system and the uterus. Serotonin, we are going to be talking about serotonin. It's derived from tryptophan, which you can get from eating turkey and other meat. Mediates mood, attachment, memory, sleep, appetite, and sexual function. The catecholamines are, I'll just start saying them before it pops up, epinephrine, norepinephrine, and dopamine. And the catecholamines are derived from tyrosine, which is another amino acid. They mediate reward, anxiety, mood, and movement. And they act as a neurotransmitter in the central and peripheral nervous systems. All of these monoamines have roles outside of the central nervous system and outside of the nervous system in general, but these are the monoamine. These are the monoamines that are involved primarily in the central nervous system. Okay. This is my best attempt at art for this. So let's talk about the way in which these neurotransmitters are used or manipulated currently by psychotropic medications. So to start off with, this is just a very brief review of your high school biology class. So this is a neuron. This is another neuron. This is an axon that transmits information away from the cell body of the neuron. This represents something like an electrical signal. It's called an action potential that moves distally away from the cell body of the axon. Of the neuron. And when it gets to the end, I didn't draw this, but it causes something called a voltage-gated calcium channel to open up. Calcium comes into the neuron. That sets off a chain reaction that results in these little baggies full of a neurotransmitter to fuse with the end of the neuron, releasing their neurotransmitter into this space in here. Anybody remember what it's called? It's a synapse. Just feel like I do a little Q&A. You're supposed to do that when you give a talk. So that's the synapse, and there are receptors waiting on the other side for whatever neurotransmitter this is that's being released. So that may be serotonin, maybe dopamine, it may be norepinephrine, et cetera. When enough of those receptors get occupied enough times, it causes some conformational changes in this axon, in this neuron, this is the dendrite, that result in an action potential being generated here, and then the signal continues. So the problem with this otherwise really nice solution that nature came up with to transmit information across or between neurons is that if the neurotransmitter is allowed to just hang out in the synapse, then it will continue to bind to those receptors, and then this neuron will continue firing, right? So the solution that nature came up with to fix that is putting vacuums on the presynaptic neuron. Those are called transporters, and they vacuum up whatever neurotransmitter this is in a recycling program, and then package them back into, well, they get packaged back into these vesicles and await another action potential. So that is basically all you really need to know about the physiology of how neurons work to understand how the vast majority of psychotropics function. Oh, it was working. Fuck. Okay, so all those happened at once. So, okay. So the main way in which sort of the canonical antidepressants, the SSRIs, work is through inhibiting those vacuums. So they're like little dust bunnies that get stuck in your vacuum and make your vacuum not work as effectively. And what that does is it enables the neurotransmitter, let's say serotonin, in like the case of an SSRI like Prozac, to hang out in here longer and thus bind more times to these receptors and thus increase the amount of signaling that happens between these neurons. When you do that globally, that essentially turns up the amount of signaling among neurons in the brain that use, in the case of Prozac, serotonin. Wellbutrin does the exact same thing, except it does it for dopamine and for norepinephrine. And then there are other agents like duloxetine, which is Cymbalta, that do it for both serotonergic neurons and for noradrenergic neurons. Okay. Another way in which pharmacologic agents can influence these pathways is to actually act like the neurotransmitter itself and bind to the postsynaptic receptor. So if this is, let's say, a serotonin neuron and these are serotonin 1A receptors, then a medication that would that binds to those and activates them at least some of the time, meaning some of the time it sits in there and does nothing, is a medication called buspirone or Buspar. And there are other more newer antidepressants that do that as one of their mechanisms of action, in addition to inhibiting reuptake. So an example of that would be Vibrid. The other thing the other mechanism that current psychotropics can do is they can bind to receptors and just sit in there and do nothing, which basically blocks that receptor from being able to be occupied and activated by the endogenous ligand that would otherwise be turning it on. So a good example of that actually would be, so the atypical antipsychotics, one of the things that they do is they block a serotonin receptor called serotonin 2A. We'll be talking more about that receptor later, some foreshadowing. That receptor inhibits, when you activate it, it inhibits dopaminergic neurotransmission, and so when you block that receptor, you're essentially inhibiting an inhibitor and thus increasing dopaminergic neurotransmission. Okay. All right, so let's talk about the agents that are probably more interesting to you guys. These are, so the broad categories are phenethylamines, and which include, probably most importantly, MDMA, also known as methylene dioxymethamphetamine, also known as ecstasy or E. And the other class is tryptamines, and those include all of the psychedelics. I told you we would be talking later, now is that time, about the serotonin 2A receptor. All psychedelics essentially activate or agonize the serotonin 2A receptor. That's what gives something the property of being a psychedelic. So the thing that differentiates the psychedelics from one another is the other things that they do, but the one thing they all have in common is they all turn on the serotonin 2A receptor. Interestingly, that's the receptor that the atypical antipsychotics block. So just by show of hands, how many people in the audience have seen these two books or know of them? Yeah, okay. So that when I was a 17-year-old and I grew up in Los Altos, I used to go to this place called Kepler's Bookstore, which is in Menlo Park, and they had this really small little section on drugs that I used to go into all the time. And when I found these books, it was just like, oh my God, this was like, I mean, that was really the beginning of a journey for me. So these are books that are written by a guy named Alexander Shulgin, who is an interesting and very influential chemist. He synthesized essentially hundreds of different versions or different analogs of phenethylamine, and as I mentioned, MDMA is one of those. And then he took them in varying doses with his wife, and then they wrote about their experiences. And so it's a big, thick book that basically talks about their experience taking all of these meds. And then actually in the first versions of the book, at least with PCOL, which by the way stands for phenethylamines I have known and loved, and TCOL is tryptamines I have known and loved. I was a little disappointed to learn that that's what it meant because it's sort of made it sound way less mystical. Anyway, in the first version, they actually gave synthesis instructions for all of the meds, and then the DEA, I think in '97, raided his lab, and after that, they stopped. The subsequent editions of the book, I believe, don't have that in there. So I happen to have one of the original. I wonder how much I could sell that for on eBay. In any case, I was terrible at organic chemistry, so I never was able to really do anything with that information. But in any case, as I mentioned, the agents that we're going to be talking about for the rest of this lecture basically have to do belong to one of these two classes, and to refer to the phenethylamines, I'm going to be talking predominantly about MDMA, and to refer to the psychedelics, I'm going to be talking predominantly about psilocybin, which is one of the psychedelic compounds that occurs naturally in psilocybin cubensis, which is the mushroom that people call the magic mushroom. Okay. Okay, why did that come back up again? Okay, so let's talk about, okay, I have to go really fast. So let's talk about the way in which ecstasy or MDMA works. So unlike Prozac, which is nice, and other SSRIs, which are nice and polite and stay outside of the neuron and just serve to inhibit the efficacy or the action of the transporters, these vacuums, MDMA actually mimics serotonin as a substrate for these and gets taken up and brought inside the presynaptic neuron. So that means it's serving as a competitive inhibitor of these, meaning it serves to allow serotonin to stay out here longer because now serotonin has to compete with ecstasy to get access to these transporters. The other thing that it does is it goes in and it inhibits an enzyme in there called vesicular monoamine transporter 2 that is the enzyme that packages all of the free serotonin that comes in back into these vesicles. And so what that means is that it allows free serotonin to hang out in this just the cytosol, the fluid that's inside this neuron. And the other thing it does is it binds to something called trace amine associated receptor 1. And what that does is when it binds to it, that activated version of TAR1 goes and there's some controversy over which one of these things does it. Either internalizes the vacuums or it turns them into little machine guns and reverses them so that it essentially, now if you put all that together, what happens is that the ecstasy gets in there, it prevents the serotonin from getting put into the baggies, it's floating around, and then it turns these vacuums into little machine guns, and so you've got all of this free serotonin in there that is now available to be shot back out into the synapse. So essentially, ecstasy and the SSRIs are more or less affecting the same pathways. It's just that ecstasy does it in a way where it floods the synapse with serotonin. And so you get a very acute and very dramatic increase in the amount of signaling that's going on among neurons that use serotonin. Does that make sense? Okay. All right. The way that psychedelics work is that's actually a much easier mechanism. They just bind to the serotonin 2A receptor and they activate it. End of story. Okay. Okay, so as I was saying at the beginning, I think what's most important for those of us that are working with patients, with real people, is how do we, for any particular patient, make an assessment about the relative risk-benefit for use of one of these medications with that particular patient. Okay, so what's interesting is normally when you are talking about risk and you're talking about medications, you're talking about biological risk. And the short of it is that these medications from a biological risk standpoint are incredibly safe. So MDMA, you can get something called serotonin syndrome, which can be fatal. But so long as you're taking it and it's pure and it is in a controlled setting, as opposed to being mixed with an amphetamine in a rave that's 100 degrees and you're sweating, the chances of getting serotonin syndrome from a therapeutic dose of MDMA are exceptionally low. One of the things that can happen is, for just like with the SSRIs and with cocaine and with lots of other things, you can, for susceptible, and with cannabis, with susceptible people, you can induce psychosis. And the same goes for mania. So for susceptible individuals, oh man, there we go. And unfortunately, that's not something that you typically can tell beforehand. Although if somebody has had a previous manic episode, meaning they have a diagnosis of bipolar disorder, probably not a good candidate for MDMA use. There is some possible neurotoxicity with long-term exposure. We don't have time to go into it. A lot of the early research that purported to show this, it turns out that the guy who was doing it had impure MDMA in his lab, and it was actually mixed with amphetamine. So it's not totally clear whether or not long-term use of MDMA causes any damage to the neurons it affects. Psilocybin can possibly induce psychosis in susceptible individuals, and it can also induce mania. That's kind of it from a biological risk perspective. The way to think about biological risk is using something called the therapeutic index. So therapeutic index is what's called the LD50 over the ED50. So the LD50 is basically the amount of it in milligrams per kilogram that it takes to kill half a population of rats, and the ED50 is the amount that it takes to basically have an effective dose. It's half of an effective dose. So you want therapeutic indexes that are really, really large. So Tylenol, for example, has like a therapeutic index of about 4 to 6, right? These have therapeutic indexes in the hundreds. So from a biological risk perspective, the use of these medications is not particularly risky. But again, I don't think that, and there's something called hallucinogen persisting perceptual disturbance, which I didn't know this, but per Dr. Reeve, who's in the audience, is personal anecdotal experience anyway, may be more likely to occur when these medications are taken by people who are younger and thus still have developing brains. Okay, so I think what's really important is looking at what is the psychological, it's awkward. Sorry, the lectern just moved. All right, I'm just gonna stand over here. Okay, so let's look at the psychological risk and benefit for these medications. So, as you guys heard earlier today in the lectures that preceded mine, there is starting to emerge quite a bit of evidence that there is benefit for the following conditions for MDMA. So post-traumatic stress disorder, social anxiety, and autistic adults. Oh man, this is such a bummer. Point it that way? Okay. So for psilocybin, there is emerging evidence that it can be helpful for cancer-related anxiety and depression. Oh, that is much better. Unipolar depression, OCD, PTSD, alcohol use disorder, and smoking cessation. And I'm sure I'm not up on all of the sort of yet unpublished trials that are being undertaken currently. There's sort of a landslide of them now. Okay, so those are the psychological conditions for which there is potential benefit. What's the potential psychological risk? So, to me, I don't think that there's been a good framework yet for how do you even assess for what that might be, right? And so what I'm going to do, wait, does this end in like 10 minutes? Is that it? It's quarter after? Yeah? Oh boy. Okay. We should just bring the musicians back up here at this point, because this. Okay. All right. So to understand to understand that, I think what we need to do is we need to look at the ways in which the current diagnostic system is inadequate for even trying to understand what the potential benefits and risks are for these things. And then I have another framework that I think would be a reasonable candidate. So this is the DSM-5. Anybody who works as a mental health care provider knows that this is the text that you go to make diagnoses. It contains essentially all the diagnostic criteria for all of the mental health disorders. The way it works is for every diagnosis, there's a threshold number of symptoms, time criteria, and typically exclusion criteria. So what are the advantages of this system? Well, it's measurable, it is objective, and it is reportable, right? So these are all things that make the mental health care industry function well, right? So because we need to be able to communicate with one another and say things like, oh, this patient has this diagnosis, and we need to be able to report to insurance companies, and there needs to be data tracking. And in order to do that, you need to have essentially a way of categorizing the symptoms that patients have that are measurable, objective, and reportable. So I think it's been a noble attempt and really the best thing that we could do currently. However, there are some substantial disadvantages, I think, to this approach to creating diagnoses. So one is it's incredibly imprecise. So for example, there are 227 ways to meet criteria for major depressive disorder. So the chance that there is a single biological entity that can be diagnosed in 227 different ways, I think is pretty unlikely, right? So what that means is that lots and lots of people are getting labeled with major depressive disorder, and in reality, they probably have multiple different processes underlying that. Conversely, I think that on the other side, I think there are probably neurologic processes or psychological processes that are very similar in origin or etiology, but manifest slightly differently between patients, and those patients may end up with different diagnoses. To me, the most that was the most important thing. So this is the most important problem, I think, with the DSM, which is that it's agnostic with respect to mechanism and etiology, right? So I think that there has been a longstanding conspiracy between the public and the field of psychiatry for us to all feel better. And what we do is the field of psychiatry comes up with diagnoses and says things like, well, you've got schizoaffective disorder. And that makes the patient's family usually say, okay, I feel so much better to know this is schizoaffective disorder. That's what they've got. Now we've got a label on this otherwise really painful and confusing and amorphous thing. And the psychiatrist gets to feel like they're a real doctor, and the family gets to feel like, I'm a psychiatrist, just in case I'm offending psychiatrists out there. And the family gets to feel like they've got something concrete to hang their hat on, right? But everybody acts like that was the same thing as getting a diagnosis of like non-Hodgkin's lymphoma, but it couldn't be farther from that. We know what non-Hodgkin's lymphoma is. We know the mechanism, we know the etiology, we have an idea about why the drugs we use to treat it might actually help with it. None of those things are true with psychiatric disorders. So this is what psychiatric disorders are like. So this is a guy, this is what it would be like if physical medicine was done the same way that psychiatry is with respect to our diagnostic approach. So you come and say, oh, I have a headache, fever, and stomach pain. And the doctor would say, yes, you appear to have headache, fever, stomach pain disease. Right? That's what psychiatric diagnoses are. When you go into the DSM, it gives you a list of symptoms, and if you've got 5 of 9 of them in the case of major depressive disorder, then that's how you get the diagnosis. But the diagnosis is nothing about what caused it, what mechanism underlies it, why do those cluster of symptoms co-occur, right? So, and again, I don't mean to be overly critical of the system, because I think that, until we understand what human consciousness is, and what the connection is between neurologic activity and the biological events that we can observe and the conscious experiences that we have, until we understand the connection between those better, I think that the empirical way that we go about making diagnoses is the best that we can do now. So I think it's the most responsible thing to do. The only issue I have is just, I feel like to some degree there is a little bit of there is not a sufficient degree of forthrightness on the part of psychiatry with respect to what our diagnoses actually are. In that, to talk about psychiatric diagnoses as though they are the same thing as biological diagnoses, I do not think is responsible. Okay. All right. So let's look. So ontogenic just means the development of the individual. So let's look at what I think is the etiology of trauma-associated disorders. Because to me, this is what we need to understand if we're going to understand how to assess the risk and benefit of the things that we are intending to do to help this person. If you are a mechanic and you are somebody brings you their car to fix it, it is important to understand, A, how does a car work? And B, why is this particular car breaking before you go in and start trying to fix it? Okay. All right. These are the things that people present to treatment with: substance use disorders, eating disorders, self-injurious behavior, pathological gambling, sex and love addiction, gaming disorder, dysfunctional anger and aggression. And because these are the things that people present to treatment with, these are the things that the treatment industry has organized itself around. There are treatment centers that specialize in each of these particular things, right? But ultimately what these things are all essentially dysfunctional coping mechanisms. They're all solutions that became their own problem. So what are they solutions for? They're solutions for emotional pain, right? The difference between somebody who goes to college and drinks and does drugs like normal college students do and then moves on with their life, and somebody who goes to college and drinks and does drugs and becomes a drug addict is that the person who drinks, who goes on to become a drug addict, the experience of being them walking around in the world sober is typically dysphoric. And that dysphoric experience typically predates their first use by years and years and years. So the difference then between the person who had sort of good enough upbringing, good enough childhood, has a sense of self that enables them to walk around in the world feeling okay, or at least neutral, when they experience intoxication, for them it's euphoric. For the person who is living with chronic dysphoria, the experience is euphoric relief, and that's a really crucial distinction. When you are in pain and you know how to get relief, or you learn how to get relief, it becomes very, very difficult not to go back and repeat that experience over and over and over again if the pain returns every time that that intervention stops. And that is why, in my opinion, without exception, people who end up going on to develop substance use disorders or addictive disorders have underlying, it's interesting, there's this term dual diagnosis. I mean, I started the dual diagnosis program at UCLA. I think it's the stupidest term in the world. I've never met a monodiagnostic alcoholic ever, right? So it just seems odd to me that that's the special case. Like, oh, this one's got depression, So the thing is, though, is that depression and anxiety in and of themselves, again, are not inherently pathological. If something sad is happening right now, appropriate to feel depressed. If something dangerous is happening, appropriate to feel anxious. It's those of us that felt depressed and anxious all or most of the time that were susceptible to developing these subsequent what I consider to be secondary coping mechanism-based disorders. So how do you end up becoming an adult who feels depressed and anxious most of the time? Because that's certainly not the natural state. And the answer to that, in my opinion, is having a sense of self that's rooted in shame. So guilt's feeling like you did something bad. Shame is feeling like you are something bad. We all need some degree of shame in our sense of self, but just enough to keep our pants on at the appropriate time and not, punch people that we're angry at and things like that, right? If we have more than that, then what ends up happening is that we end up feeling bad most of the time. So how do you end up being a person that has too much shame in your sense of self? And the answer to that is basically through, I try not to use the word trauma because I feel like it makes us sound histrionic to the rest of the world, right? So I work a lot with patients who, and I have to speak with parents who parented those kids who have developmental issues. And when, most people's understanding of trauma is like what happens in combat. And so, again, I prefer to use the term developmental injury, but really what I'm talking about here is what's commonly referred to as developmental trauma. Okay. All right. Dude, Okay, so I've only got, is there a panel after me? Can I go over by like 2 minutes? Okay, all right. Okay, so phylogenetic basically just means the development of the species, right? So why is it that humans, like evolutionarily, why did we become creatures that were prone to these trauma-related disorders? Okay, there's a real challenge to being a social mammal, and the challenge comes from the fact that the world, the universe, just like mathematically consists of zero-sum and non-zero-sum games, right? And zero-sum games or zero-sum interactions are ones where there is a winner and a loser. It's like when you're negotiating for a car, right? Every dollar that you get down is a dollar. Every dollar in your pocket is a dollar out of the car dealership's pocket. Zero-sum interactions are competitive interactions. But there's plenty of interactions that are non-zero-sum. In fact, most of what we engage in as humans are non-zero-sum, where essentially they're win-win interactions, right? So zero-sum interactions are win-lose. Competition for resources is the origin of them. They manifest in humans as dominance hierarchy. They're experienced emotionally as a reward and loss. These are our ego-based emotions, and they are, mediated predominantly by dopaminergic pathways. Okay. Non-zero-sum interactions are win-win. They involve the emergent benefits of cooperation. They manifest in humans as kin and non-kin attachment. And they're experienced as love on the positive side and loneliness on the negative side. And these are mediated, these are more of the selfless emotions, and these are mediated primarily by serotonin, which will hopefully show up soon. Okay, so, and I don't need, but basically the prisoner's dilemma is the essence of like human drama. Essentially, it's how do we mediate between the fact that we live in a world where we are adapted to cooperate, but also to compete. And most of the tension in any novel or movie that you see has to do with this tension. It's like, oh, the betrayal. Like The Sopranos is a perfect example, right? I thought they were loyal to me. I was betrayed. Or like when I was like an hour late for on my flight coming up here, and the plane was delayed for an hour, and I was like, and they kept saying, oh, well, we're gonna fucking Southwest, and it was like, oh, there's some passenger still needs to deplane, and it was like, it literally took an hour, and I was just like, the hatred in my soul for the person who was on the plane. I mean, I'm like, man, I am gonna look that motherfucker right in the eyes when they come out, and just make them feel so bad. And you know what happened? It was a 12-year-old kid with cerebral palsy on a stretcher. And I'm like, oh my God, I'm a horrific human being. Like literally, it was the worst afternoon I've had in a long time. But that's another example of these competing things, right? Where I went from a very dominance hierarchy, anger, competition for resources type of mentality to one that involved empathy, right? So, okay. So this, I've represented it this way, and I'm just going to breeze through this. This is too bad that I have to go through so quick, because this was the part of the talk I thought was pretty cool. So basically, I think you can conceptualize that those oftentimes conflicting orientations or adaptive strategies through this graph here, right? So, and healthy attachment is on the positive side of affiliation, right? Now, you can have attachment where you're in a dominant role, like the way that you feel when you love your kid or are coaching a little league team, but not in a weird way. You know what I mean? Like just kidding. I don't even know why I said that. It's another example of things that go wrong when I give talks is they come into my head and I say them out loud. But this quadrant represents essentially attachment when you're in a dominant role. But there is also attachment from a subordinate role, which is the type of love that we feel when we feel loved and taken care of by our parents. I also believe that our spiritual feelings as adults are mediated by this submissive attachment or selfless attachment or non-ego based attachment. Now, if you have disrupted attachment, which in my opinion, that's what the disorders of trauma are essentially disorders of disrupted attachment. If you are dominant, right, then you experience that as anger, and if you are in a subordinate role, you experience it as shame. So anger and shame are the same emotion. Anger is just shame pointed outward, and shame is anger pointed inward. There's a great documentary on Netflix about Mike Tyson that you guys should all watch. It's an incredible demonstration of this, right? So Mike Tyson was bullied ruthlessly, and oh boy, here comes Dr. Smith. I gotta wrap up, huh? All right. Feel like I'm in trouble. So, okay, I'm gonna wrap it up. Okay, so anyway, it's called Tyson. You should check it out. It's really good. Okay, these are the narcissistic defenses, right? So every narcissist out there that you hate, underneath it, they feel incredible shame and less thanness and aloneness and isolation, and they use the narcissism as a defense. If you aren't able to access that, meaning if you're have insufficient ego strength, then you end up with depressive and anxiety disorders. So, okay, more dopamine makes you feel more dominant, less dopamine makes you feel less dominant. Any of you who've done cocaine like I have know that this is how you feel when you do cocaine, where you feel like awesome and you're, I'm so incredible. And then when you come down, you're like, I'm a terrible person. Serotonin mediates affiliation. The lack of serotonin mediates aggression. So serotonergic agents move people this way. Dopaminergic agents move people that way. Anti-dopaminergic agents move people this way. Here's what's really fascinating, and this was the part that was sort of like the punchline of the whole talk, is psychedelics are serotonergic agents, but they bind to 5-HT2A, which inhibits dopamine. So guess what? From a pharmacologic perspective, we would expect psychedelic agents to actually move you more into this corner, and that's actually what it feels. These are the things: spirituality, egoless attachment, the type of love that we feel in childhood. Those tend to be the things that I think subjectively get reported by as people who are taking psychedelics. Okay, I think I'm gonna probably have to just blow through this one really fast. So, okay. And so Freud broke the mind up into three things: the ego, the id, and the superego. This doesn't mean ego like the way we normally talk about ego. Here just means like you are the mediator, your ego, between your id and your superego. Your id is your drives, your superego is your consciousness or internalized parents. They're like an angry jury that sits here, especially if you had overly critical parents. And when you are healthy, you have a healthy mix of the two. When you are depressed, you have too much superego and not enough id. And when you're manic, it's the opposite. And essentially, what psychotherapy, 12-step, and spiritual practice do, in my opinion, is they go in and they help you reform your superego. Those of us who have shame or trauma-related disorders, it's because we have an overly critical superego, and all of your relationships that were potentially abusive, either with adults or peers or whatever, those are people who live in your superego on that jury telling you that you're not good. So reforming the superego is what we do in psychodynamic psychotherapy, in 12-step, and in spiritual practices. And so now let's use all that to look at this is the last slide. The benefits and risks of 5-HT2A agonists. So they expedite this mechanism of psychodynamic therapy and spiritual practice. They help remove the intrapsychic barriers to change, meaning suppression, denial, and narcissism. So that's the benefit. But what's the risk? It's that they remove the intrapsychic barriers to change. Meaning it's like these intrapsychic barriers to change, suppression, denial, narcissism, all of these dysfunctional coping mechanisms are like tourniquets that we put on during our development so that we can survive our childhood. And then our adult problems are from the tourniquet. And then what happens is we go into psychotherapy, we get into 12-step, we have spiritual practices, and we gradually take that tourniquet off and develop better coping mechanisms. The risk, I think, of taking an agent that helps you take off that tourniquet is just that, if you blow the tourniquet off all at once and you haven't got anything else in place, it's a little bit of a setup for emotional collapse. And that's why I think if you look at what's happening with people who are having bad trips out there, particularly the ones that have a bad trip that then persists and causes ongoing problems, it's usually because it disabled what actually probably is a dysfunctional coping mechanism, but was the only coping mechanism that that person had, and they weren't in therapy, and they didn't have spiritual practice, and they weren't doing other things to give them healthy coping mechanisms to replace that. So what does that mean? It means that set and setting, which has been the thing that everybody's been saying forever, is really important if you're going to use these agents so that you actually help prepare people when the tourniquet starts coming off. Okay. And that is only 10 minutes over. All right, sorry.